Well, welcome everybody. It's a pleasure to introduce this topic. It's a hot topic today and a controversial one as well. It's been in the news quite a lot over the last few months, no more so than in particular over the last week or so. We're going to be talking about bariatric surgery abroad and issues to consider. So I'm just going to share my screen. In the meantime, as the team have said, if you have any questions about bariatric surgery in general, it doesn't have to be necessarily related to tonight's topic, just feel free to ask in the chat. We will be here till about 8 o'clock, trying to answer as many of your questions as we possibly can. And then if there are any other questions that I've not been able to answer or perhaps may be a good basis of a future talk, I can certainly come back in the future and give you another presentation. So, bariatric surgery abroad and what you need to know. Before we start going on to the topic of bariatric surgery, let's just cover the basics. So, obesity, as we know, is an excessive accumulation of fat that importantly poses a risk to health. We define as obesity as medical professionals as a body mass index of 30 kilograms per meter squared, or 30 points, whichever you want to use. And the body mass index basically takes into consideration a person's weight in relation to their height. It's not a perfect tool by any stretch of the imagination, but it helps us understand risk in terms of health. The higher your BMI, generally speaking, the higher the risk to health. From a UK's perspective, we know that obesity is widespread. From a recent report in 2021, we know that 26% of people, of adults in the UK, suffers from obesity, and 2/3 of adults are either overweight or have obesity. More worryingly, of course, is the prevalence of obesity and overweight in children aged between 2 and 15, and we estimate anywhere in the region of about 1/4 to 1/3. So that tells us that this problem isn't going away anytime soon. What we do know is bariatric surgery is a powerful, safe, and effective tool to help us address obesity, not just in the short term, but also in the long term. It also results in the reversal of many medical conditions linked to obesity, including type 2 diabetes, osteoarthritis, because of the sheer weight on people's joints. It reduces the risk related to stroke, the risk related to cancer. It results in an extended life expectancy and generally an improved general health-related quality of life and overall well-being. One of the biggest challenges that we are facing is the unmet need for bariatric surgery. In a study from 2019, we saw that there was anywhere between 3.5 to 4 million people in the UK that could potentially be eligible for bariatric surgery. That was a pre-COVID study. And what we do know about COVID is lots of people have gained weight since then. And as a result of COVID, that's certainly one of the drivers when I see people. And so we could probably say that that figure is closer to 4 million. Unfortunately, in the UK, we're only undertaking anywhere from about 5,000 to 6,000 bariatric operations every single year. So you can see the demand is massively outstripping the supply for bariatric surgery. Let's talk just briefly about eligibility criteria. I'm sure people on the call today will know a lot about this. The National Institute for Health and Clinical Excellence, or NICE, is the national body in the UK which gives us the guidelines on which to base bariatric surgery eligibility criteria. If your body mass index is greater than 40, you're eligible for bariatric surgery. If your BMI is greater than 35 with a weight-related medical condition that would benefit from weight loss surgery, then you're eligible. We know in more recent years, there's been a development in the criteria so that if you have developed in the last 10 years type 2 diabetes and your BMI is greater than 30, you are eligible for bariatric surgery. And we are also aware that certain other factors influence risk in terms of type 2 diabetes and high blood pressure or those types of metabolic conditions, particularly South Asian ethnicity. So the eligibility criteria drops even further by 2.5 points if you have a South Asian background. However, these criteria are old. Quite a lot of the criteria are dogmatic. That means they're based on previous practice and not necessarily best evidence. And what we know now, and more recently, we've seen new guidance from the International Federation of Surgery for Obesity, which suggests that if people are BMI of 35 and over without medical conditions, they should be considered for weight loss surgery. And if your BMI is greater than 30 plus with weight-related medical conditions, or if you can demonstrate that you've done lots of different things over the years to lose weight, then again, it's a safe and effective treatment. However, in the UK, we have to rely on the NICE guidelines. But even then, we know that it's, as a cliche goes, it's a postcode lottery. So each region has its own set of criteria. Some regions don't follow the NICE criteria or the NICE guidelines, and the bar for accessing bariatric surgery is a lot higher. I don't want to really go too much into the detail here, but this is an illustration of the pathway from referral from your GP to surgery on the NHS. It's long, it's protracted, there's lots of steps to it. And as many people on the call today will know, it can take 2, 3, sometimes 4 years for you to access bariatric surgery. On top of that, we know that COVID has really hit the services hard, although we are trying our very best to regain some of that lost ground. So they're the challenges for accessing bariatric surgery on the NHS. And as a consequence, what we find is people are now looking outside of the NHS. They're looking to self-pay. They're looking to fund their own bariatric surgery in the private sector. And one of the biggest challenges that we see is cost. Currently, we're looking at anywhere from around £9,000 or £10,000 at the very least for bariatric surgery privately, compared to other regions such as Turkey, such as Egypt, such as Europe, which are 3 times cheaper or twice as cheap compared to UK prices. We know that whilst a lot of people will either self-fund by part payment or taking out finance or loans or credit, that might not be the answer for everybody. And certainly when people are looking at price comparisons, it's very attractive to look abroad where the cost of bariatric surgery is a lot cheaper. And what I want to do today is explore that topic a little bit further. So here's a couple of examples. These in particular from Turkey. They could be from anywhere really. And one of the other things that attracts people to bariatric surgery abroad is the aggressive advertising strategies that we're seeing. We're seeing people who are offered cut price bariatric surgery, Botox is being thrown in, teeth whitening is being thrown in, hair transplants are being thrown in as well. And so that raises some concerns as to what is the strategy here? What's the focus? Why are people doing these things? And we're going to talk about that in due course. More recently, I've picked up that actually they're not just advertising on the internet or on social media, but surgeons and teams and agencies are actually flying out to the UK. And in particular, there's a roadshow that is being planned in the UK. And of course, I'm not going to give any information out about that. There's also concerns about the accuracy of the information that's being provided by agencies and parties abroad and providers abroad. This is one example of a clinic which purports that it's undertaken 50,000 operations, bariatric surgery operations, without a single complication, which is, of course, utter nonsense, because we as surgeons know that we know what the complication rates are. We operate to very high standards in the United Kingdom, and 50,000 operations, you're bound to have some complications as a result. So you have to question the accuracy and the reliability of the information that's being given to patients. Many of you will have recently watched a BBC documentary on the topic and heard how the market was filled, or the marketing and advertising was filled with fake reviews, stolen profiles. And of course, now with artificial intelligence, AI, it's really going to be very, very difficult to detect what's real and what's not. We also heard from the documentary that there were 30 or so clinics contacted, and at least a quarter of them were offering surgery to people with normal body mass indexes. Some clinics were even advocating patients to put weight on in order for them to then qualify for surgery. So all of that is ethically reprehensible behavior, of course. In more recent news, we've seen, some really bad reports of really severe complications and severe consequences of surgery abroad, including deaths and severe complications. And unfortunately, only this week we've heard in the news of a poor woman who passed away last Saturday, undergoing gastric surgery. They've referred to it as gastric band surgery, as sleeve gastrectomy surgery, who was based up in Scotland. I want to talk briefly about red flags. If you are thinking about looking abroad, I want you to think very carefully about cut price deals and what that actually means and the implications of that. We'll be talking about and touching upon that in more detail in a second. We're hearing people are given access to surgery within a week or two. And really, you have to question how busy and how experienced a practice is if they are so free that they are able to offer people surgery within a week's notice. And certainly when they're saying yes very, very quickly, without any formal assessment, they may be asking for name, date of birth, a list of medications, and that's it. There's no formal preoperative assessment made before a yes is given and you booked in and you paid for your flights and everything before you go across to Turkey or to Egypt or to whichever region it may be. Relaxed eligibility criteria. Well, we've talked about how some clinics are offering dubious eligibility criteria, dubious services in terms of a sleeve gastrectomy at a BMI of less than 30, which is startling. And of course, the added extras that we've touched upon as well, your teeth whitening, your Botox, your hair transplants, that's really trivializing the type of surgery that we're discussing here. Bariatric surgery is invasive surgery. It is linked with some small risks of complications, and it needs to be taken seriously. I want to share with you our personal experience of health tourism linked to bariatric surgery in Salford Royal. And one of our clinical attaches has recently undertaken a research project looking at the impact of health tourism on resources within the NHS. What we found is over the last 3 years since COVID, emergency admissions linked to bariatric surgery have been associated with overseas travel or bariatric surgery abroad in 1 in 4 cases. And this rate is increasing year on year. In last year, in 2022, apologies, we had 30 patients with severe complications as a result of surgery abroad. And in fact, very, very recently, only in the last week or two, we've had a staggering 10 patients in at any one time. We've had patients who have become septic on the plane, who have come directly from the airport. And of course, we've had patients who have not had the surgery that they thought they had, and we've only realized after we've had to go in and do another operation or do some further tests. And these are all concerning, of course. Now, it's really important that we don't bash every single person who is offering surgery abroad. Not all clinics are the same, of course. Not all surgeons are of the same level. Some are very, very experienced, and I personally have some very close colleagues and friends in some of these regions who are very experienced. But one thing that we must do is really take a step back and think carefully about how we navigate through this heap of social media advertising and aggressive advertising and reviews, whether they're real or otherwise. So I want to share with you just briefly some of my thoughts, and I've got 6 areas that I want to really focus on. Some of these recommendations or key factors can be applied to people wanting to seek private surgery or self-paying surgery here in the UK as well. So right at the top of the tree, the number one consideration has to be the quality of care. It's the most important thing that you have to think about. You must check out the credentials of the surgeons. You must check out the credentials and the outcomes and the results of the hospital as well. In the UK, we have something called the Care Quality Commission, the CQC, which is an independent body that assesses and grades the standards that we deliver and that we operate at. And that's not just in the NHS, but in the private sector as well. So we have minimum standards, and the ratings of these institutions and these hospitals and clinics are publicly available to you. The other thing that you have to be mindful of, and you should ask your surgeons this, again, whether this is in the NHS or otherwise, is about a person's complication rate. What is the surgeon's complication rate? Don't be afraid to ask. A surgeon should know their complication rate. And certainly in the UK, we have to submit our outcomes and our results for all our operations to a national registry, again, which is published on an annual basis by the British Society for Obesity and Metabolic Surgery as well. Speak to more than one provider. So if you are contemplating surgery outside the NHS for whatever reason, then make sure that you hear from more than one person, because everyone has a slightly different perspective and there may not be one perfect answer for all. For me and for my colleagues, aftercare is as important as the surgery itself. Surgery is, of course, key. It's the tool that's going to help you make the changes and achieve the results that you want to achieve. But without the aftercare and support, there's a big chance that you might run into problems and you might not then achieve the results that you want to achieve in the longer term. It's critically important for that reason. It's critically important because the aftercare team, and that includes not just the surgeons, the medical doctors, but also the nurses, the psychologists, the physiotherapists, the dietitians, and a whole host of allied health professionals will help you identify issues early on so that we can address them so that they don't go on to become chronic issues which impact on long-term outcomes and long-term results. The aftercare team and the support team are really important for offering medication guidance, particularly in terms of supplementation and medication in the longer term, adjusting certain levels of medications that you might need, increasing supplementation, etc. And that's another key important feature of aftercare and support. From a short-term perspective, you need to have the trust and the reassurance that the team that's going to be looking after you is going to discharge you appropriately from hospital. You don't want to be leaving hospital when you're not right and when you're not ill. And one of the themes that we are seeing coming out from some of the services abroad is that patients are being discharged inappropriately when they're not ready for discharge, when they're not taking enough fluids, and maybe when they are suffering with other problems, including infections, etc. Early recognition of complications is really, really important, because the earlier we recognize problems, the earlier we can put them right and the better the outcomes are for patients. As I said right at the beginning, we cannot eliminate the risk of complications. If you're a patient in the UK, that doesn't mean that you're never going to have a complication. But what's important is that we can identify them early and put them right. Another consideration that you have to bear in mind is that if you are having surgery abroad, then routine aftercare is not going to be provided by your GP, and certainly not by us in our Tier 4 bariatric surgical centre. Of course, if there's an emergency, we will not turn you away, and we will offer you the recommended or the necessary treatment to help you out. But in the longer term, you will have to return to the the provider for that aftercare. Cost is another thing. You really need to think carefully about what you're paying for. If it's being advertised as £3,000, what does that include? Does it include travel? Does it include insurance? Does it include accommodation? What about if somebody needs to come out with you and give you that additional support? Does it include the cost of their accommodation and their stay as well? What about follow-up? Most of our experience is that once people come back from abroad, they get no follow-up at all. And as I said, we would not be able to provide that routine follow-up for you in the future. Aftercare and support is vitally important, particularly in the longer term. And we believe strongly that if you don't get the right aftercare, you're probably not going to get the longer term sustainable results in the future. Beware of cut price deals. You get what you pay for. All the adages, all the cliches, you pay cheap, pay twice. It's not just about financial cost, but there are other costs. There are health costs implications here about making sure that you choose the right provider. It goes without saying, if you go into a country that doesn't speak English as its first language, there's going to be potential language barriers. Communication, in particular in healthcare, is vitally important. Think carefully about how this might affect you, especially if you have problems or run into complications. How are you going to communicate with your medical team? How is your medical team going to communicate with you? How are you going to get across the messages that you need to get to them? And communication and language is one thing, but culture is yet another thing. We have our British sensibilities. We've been raised and brought up in a way. There are a lot of assumptions that we make in terms of healthcare, what's expected, what the minimum standards are. That might not be the case abroad. So you really need to do a lot of research and explore what's the cultural implications of having surgery abroad. You know, is it normal in certain cultures for them to have surgery, be out of hospital and be housed and looked after by their family at home? These are things that you need to think very carefully about. Legal regulations are different in different parts of the world. You know, we have our standards, as we've said already today. We have minimum standards. We're governed by the Care Quality Commission, the CQC. As surgeons, we're all indemnified. We have accreditations. We've undergone the necessary training and fellowship training as well. And all of these may not be offered or maybe as a standard in some of the centres or clinics that you may be looking at. The other thing to bear in mind, we've already touched upon it, is that bariatric surgery in some areas is seen as more of a cosmetic surgery and therefore falls under cosmetic surgery regulations. And you should look at that and see whether that applies in the region that you're looking at, if you are looking at hospitals abroad. In the UK, we're very clear this is not cosmetic surgery. This is you know, invasive surgery, which is geared at improving health and quality of life, and does carry with it some small risks of complications, and it needs to be taken seriously. Finally, recovery time and travel. You know, you're going to need additional time off work if you're getting on a plane, taking a coach, or whatever you decide to do, and that might have an impact on you and your work as well. There are, of course, additional risks to flying. Many of us will be aware of the fact that if you fly, there is an increased risk of developing clots to the legs and lungs, and they can potentially be fatal if they're not treated and the risks aren't appropriately mitigated. Here in the UK, at the very least, everybody will go home with injections to thin the blood to reduce the risk of clots. But of course, the risk of clots increases if you are flying because of a lack of movement and the restrictions you've got in the chair. If you get stuck abroad, does your health insurance cover you? That's a question that you have to ask. And finally, if you do have a complication or return with a problem, will the airline agree to bring you back without additional costs? So that again goes back to costs and fees. If you look for a cut price deal, then there may be implications in the longer term. So I'm going to summarize that. Number one, there's absolutely an unmet need in the UK for bariatric surgery. Bariatric surgery is generally safe. It is extremely powerful. I personally and my colleagues personally don't blame people for looking outside of the NHS because they are almost being stopped from the treatment that is required for them to make the improvements and make the advances in their health that they need. Without doubt, the price and the cost of surgery, even within the UK, in tandem with aggressive marketing strategies, it's certainly driving demand for surgery abroad. But there are serious implications to health and long-term results that you really need to think about very, very carefully. As I said, this is not about making a decision or telling you what to do. Ultimately, everyone needs to make their own decisions, but it needs to be an informed choice. Thank you very much.
Thank you. That was really interesting. And I think.
So we've got 99 plus in the chat.
Yeah, I think it gave everyone some really good things to think about.
17 questions, gosh. Right. So here we go. So should we start from the top? Well, there's lots of hellos and highs. Should we go in the Q&A bit?
Yeah, if you go in the Q&A, I've picked up a few from the chat box that I can add to it. But if we stick to the Q&A,
if you would, so if you wouldn't mind doing that, so let's do that. When having the surgery done at Castle Hill, how long are we in for, and are we allowed someone to stay with us? So that's a more a logistical question to ask. Generally speaking, in the NHS, even any hospitals, you wouldn't have a relative stay in the hospital with you. Most people will be home after a day or two. We have something called an enhanced recovery program where we generally like to speed up people's post-operative recovery. People are always better, generally speaking, recovering in their own home. And so generally 1 or 2 nights in hospital is more than required. Of course, if you have additional, more complex needs, more social needs, everyone's on a case-by-case basis. How long do you wait for urgent surgery at Salford? So we talked about the 3-year business being a routine pathway. We are seeing more expedited or more urgent referrals being processed in 6 months, there or thereabouts. There are certain circumstances where patients qualify for more expedited or urgent surgery. I'll give you an example now. Endometrial cancer patients, we know that patients who have endometrial cancer and have bariatric surgery, for a lot of them, their endometrial cancer or dysplasia or abnormal cells goes into remission. There are other types of cancers that require surgery whereby surgery can't be undertaken unless a patient loses a significant amount of weight. There may be certain circumstances where a patient is needing to go on a kidney transplant list and they're unable to access that until they lose weight. So there are examples of surgeries or cases whereby we would expedite and not rush surgery through, but we would speed up the process. You're talking about 6 months, there or thereabouts. Would you be able to do the Roux-en-Y bypass if your BMI is between 60 to 65, or does it have to be below 60? Okay, so that's a more technical question about eligibility and the choices that we make. Generally speaking, our approach at Salford anyway would be to be pragmatic. When we operate on somebody who's got a very, very high body mass index or very high weight, there are significant technical challenges associated with that. And so our approach to somebody who's got a very high BMI of greater than 60 would be to do something in the first instance, such as either weight loss injections, which are all the rage now, and that will be under direct supervision from our medical weight management team, or we would offer them a two-staged approach where you may have a sleeve gastrectomy first, reduce your weight, and then go on to have a gastric bypass in the future if the need arises. So it's unlikely that we would offer you a bypass if your BMI is more than 60 just because of the technical challenges associated with that. But we would find another strategy in order to address your weight, if that makes sense. I've looked at going abroad as I can't meet my 5% target. I had my 4-in-1, but for some reason, you lost me in the system. I went on to have children. My health is so bad, I can barely walk. I have lupus. Surely the NHS can make some exception. So again, you would need to, we'll be very happy to look at, individual cases if we think you've been lost to follow up and pick things up. Abby, do people have Jodie's details at Salford?
I've taken a note of this client's name.
Okay.
So I'll get in touch. Yeah.
Okay. Urgent basis accepted by the bariatric team. What are the expected next steps? So we've talked about that briefly, Charlotte. Generally speaking, depends how urgent. So if it's vitally urgent, you may bypass tier 3 weight management altogether and just have an information session, or tier 3 may be shortened significantly. It very much depends on a case-by-case basis. Pernicious anemia already, would that stop me from surgery? No, it wouldn't. And again, this highlights the importance of having an appropriate workup to surgery. Surgery is very rarely contraindicated or can't be performed. But what we must do in a lot of cases is optimize patients. It's about making sure that surgery is as safe as possible for you. We are not in the business of escalated risk at all. We want to make sure ultimately that patients have a safe experience, they have the minimum risk of complications possible, and they go on to have an excellent outcome in the short and longer term. So there may be certain conditions that we need to optimize and make better before then you can go on to have surgery. If 1 in 4 complications are from health tourism, that means 3 in 4 from surgery here. What type of complications do you see from people who have had operations with yourself? That's an excellent question. So one of the big factors that we are unaware of is the number of people who have had surgery abroad. So as I said, this is not about tarnishing all surgery abroad with the same brush. Undoubtedly, this is not about saying that if you have surgery abroad, you will have a complication. That's not what I'm saying at all. And without really understanding the number of people who are physically going abroad to have surgery, we can't really comment on complication rates as such. But that also points to the fact that we're dealing with an unregulated system. We are heavily regulated here for a good reason, for the benefit of patient health and patient care. And we have to attain certain standards. What we do know is we are but patients are going across into a largely unregulated system where they are having to navigate through certain regulations and certain jargon and health speak and communicate in a language that the person in front of them may not speak as their first language, and have all of these risks and challenges, when really we need to make sure that the environment that patients are having surgery in is as safe as possible. Let's talk about the 3/4 of patients who have complications in the UK. So the profile is different. What we find is that from patients who are based in the UK, the complications that they're presenting with are far more to do with the gastric band rather than with the sleeve or the bypass. So one of our clinical attachment doctors is currently undertaking a research project in this, looking at how patients present in an emergency. And by and large, the biggest proportion of patients from UK, who've had their surgery in the UK, are presenting with band-related complications such as slipped band, infections, erosions, all kinds of other things. And we certainly don't offer the gastric band, and it's more of a legacy of that in the past. We still need to do a bit more analysis on the sleeve and the bypass, but certainly the the number of cases that we're seeing related to the sleeve and the bypass are far less in patients who seem to be having their surgery in the UK. Does a long wait time for surgery apply to going outside of the NHS in the UK going private? Also, would it be safe to get weight loss surgery before or after having surgery? So no, generally speaking, the wait times are not long for private healthcare. You're talking 6 to 8 weeks in general for people who are pursuing bariatric surgery in the private sector. It's absolutely safe for you to have bariatric surgery before and after. It's absolutely safe to have to plan pregnancies after bariatric surgery or before having bariatric surgery. It's entirely your choice. What we would say, however, is that you should wait at least 12 to 18 months after having bariatric surgery before planning a pregnancy, because that allows you the opportunity to maximize your weight loss and also allows us to make sure that your nutritional levels have stabilized. That being said, I have had several patients who have fallen pregnant within the first year, and we've certainly been able to support them to have a safe pregnancy. I've completed lots of research, just about tried every diet and lifestyle change possible, and had both my mum and sister go through the surgery privately. Is there anything I can be researching, looking into, broaden my knowledge? So these forums are really important because you are getting information from reputable sources. One of the double-edged swords that we have available to us is social media. And it's sometimes very difficult to get a real and balanced understanding of the different options. In terms of books and things, I personally wouldn't, there's no books that I say, oh, you must read this or you must read that. But get different perspectives, speak to different surgeons, speak to different providers and teams, listen to some YouTube videos from reputable surgeons who have large followings, people who you might not necessarily have access to and therefore might not be negatively influenced by. So there are a number of individuals that we could certainly provide further information to you about. What sort of food do you have afterwards? So I'm going to leave that, I think, to Nina, who's from nutrition side of things.
Yes, I'm happy to answer that. So I'm Nina, so I'm dietetic lead at More Life. So the types of foods that you can have afterwards. So immediately afterwards, you need a completely liquid diet. So that would depend on which type of surgery. That might last 2 or 3 weeks. And then you would move on to a pureed diet. And again, that would last a few weeks. And then you would move on to a soft food diet, and you'd be eating very small portions of these foods. Following that, you then are able to include different food groups, but you would still need to be careful with things like your portion size. So we do recommend the 20-20-20 rule. So having food no bigger than a 20 piece coin, chewing it 20 times and waiting 20 seconds before then eating again. So it will impact your eating lifelong after having the surgery and the portions that you can eat. We would also recommend sticking to a low-fat, low-sugar diet. If you do have foods that are high in fat and sugar, it can lead to some unpleasant side effects, such as dumping syndrome. Things also to consider are things like fizzy drinks. If you have fizzy drinks, again, it could cause some nausea, some reflux, and alcohol as well. We wouldn't recommend drinking alcohol after surgery. So immediately after surgery, there is a strict diet to follow, and you will get advice from Chris, who's the dietitian who works at Salford. But lifelong, really, there are dietary implications after following surgery, and you would have to take supplements as well alongside what you are eating. So I hope that answered the question.
And I think what you've just demonstrated there is the importance, again, of a comprehensive aftercare group and a comprehensive aftercare team, because there are going to be lots of obstacles for people to navigate through. You know, we live, eat and breathe this on a daily basis. We know these things, and even we don't have all the answers. So what of somebody who's, you know, having this surgery, and, you know, a lot of the information can be overwhelming. Certainly, you know, the amount of information that we provide for you right at the beginning of the process, realistically, people aren't going to be expected to learn and remember everything. And so you're going to have access to people who can help you and support you through the process. And again, think very carefully about providers that you go with and whether they will realistically be able to provide that help and support for you in the longer term. A question on blood thinners, and does this pose a problem for surgery? Again, no is the short answer. It's about how do we manage the problem. Blood thinners in particular carries with it some special considerations. You'll need to stop your blood thinners ahead of surgery so that you don't increase your risk of bleeding at the time of surgery. But there are certain blood thinners that aren't as effective in the post-operative period. So, for example, some of the newer blood thinners, such as apixaban or rivaroxaban, they are not well absorbed by the gut after a gastric bypass. And for those patients, they would need to transfer from apixaban to a drug called warfarin to thin their blood. And there are implications for that, because with warfarin, you need regular blood tests, whereas with apixaban, you don't need to have blood tests on a regular basis. That's less of a problem with the sleeve gastrectomy, because the apixaban medications are absorbed in the first part of the intestine, which we're not touching at all with that type of surgery. So the short answer is no. That's not a reason not to have surgery, but we just need to manage your medication around the time of surgery. I have a brain aneurysm which is under review and I'm waiting for treatment. Does this affect my place on the waiting list? So that, again, the answer is no. It depends on where you are on the waiting list. If you've already been given the green light to go ahead for surgery and this has cropped up, we certainly wouldn't expect you to go right to the bottom again. You would again need further investigation. If you still haven't reached the surgical clinic, then again, that won't slow things down. Those two pathways can run in parallel, and we just wouldn't perform the surgery until your treatment for the brain aneurysm has been undertaken. If it's not classed as cosmetic surgery in the NHS, why is it not more freely offered? Why don't they do it in all main hospitals? That's a really good question. I wish it was. I honestly wish it was. This is probably, out of all the treatments that I offer, I treat cancer of the stomach and the esophagus. I treat benign, non-cancerous medical conditions, and I also treat obesity. And by far and away, the treatment that results in the greatest impact on patients is bariatric surgery. And yes, you're absolutely right. It should be more widely available. You certainly have our sympathy. It is a political decision. It's not in our hands, unfortunately. We've seen that from a political perspective, there needs to be far more done to prevent obesity developing in the first place by addressing, education, by making sure that we understand what healthy and balanced nutrition looks like. And that starts from the schools and from families and from communities. But at the same time, we can't forget about people who are already in a position where they're stuck in a rut, or whether they're in a negative cycle and they can't get out of it. And for the majority of people with a BMI of greater than 30 and 35 and 40, I'm talking about more than 95% of people are simply not going to achieve the weight loss that they need through diet and exercise alone. It's just not going to work. And there's good physiological and biological evidence or reasons why that is the case. When we try to lose energy, when we try to lose weight through starving ourselves or by upping our energy expenditure by exercise, it might work for a month or so. And then what happens is the brain says, I don't like this. It's a mechanism, it's a protective mechanism that the brain has. What it does is then it starts increasing your hunger hormones, reducing your metabolism, and then you stop losing weight. And in fact, most people will end up putting more weight on than they started off with. So you're absolutely right. You have our complete sympathy. It's a political decision that really needs urgent redress. You need to know that there are national groups fighting hard for the cause to make sure that this is more freely and widely available. Ultimately, we are in a system where there's finite and limited resources. These resources need to be allocated appropriately. And unfortunately, these allocations are undertaken by politicians. The benefit of bariatric surgery for most is seen in the first year or two. For the wider population, it often takes many, many years for us to see the large scale benefits in terms of reduced medication, reduced impact on services. And when you're talking about governments who are only thinking 2 years until the next, local elections or the next general elections, the focus isn't very much in the long term, it's very much in the short term. Would I still be able to have surgery if I had factor V Leiden? Factor V Leiden increases your risk of bleeding. Absolutely. That's not an issue. I've operated on lots of people who have factor V Leiden deficiency. Again, it's about having a plan around the time of surgery to treat you safely. Let me have a look. Have I jumped? No. Do you think the availability of the new weight loss drugs will be more readily available soon? I hope so. It's certainly becoming more established. I think that where we're going to see the future of these medications, I hope that they'll be available in primary care. At the minute we're going to be giving them out in secondary care through supervised groups, but I suspect that as they become more and more widespread and available, we're going to see more availability in primary care of these medications. I just need to, give a word of caution. There's been a lot of advertising and a lot of fanfare about these injections. They're not going to cure people from obesity. They're not going to be the long-term solution for most people with a BMI of greater than 35 and 40, unfortunately. These medications will result in a modest reduction in weight, but when the injections stop, then the weight comes back on for most people. There's also an issue about tolerance. Some people can't tolerate the side effects from these medications. And so whilst they're a good tool in our toolbox, there's certainly not going to be this silver bullet that's going to fix everything. It's probably going to make our surgery more effective because we can start to begin using these injections in conjunction with surgery. And I certainly believe that there's lots of exciting developments that's going to happen in this area, in this field of injectable medications. And who knows, maybe surgery will be completely defunct in the future, but I just don't think that that's going to happen anytime soon. If someone wants to pay for surgery in the UK, how much does it usually cost, and do they also do aftercare? So it's in the region of about £10,000 for a sleeve, maybe a little bit more than a bypass. And absolutely, everyone will offer aftercare as standard. As I said, there's basic minimum standards. You need to do your shopping around, contact more than one provider, and look at your options. Really understand what the aftercare is. Not all aftercare packages are the same. Do they include dietitian? Do they include physiotherapy as well as the bariatric nurse? What's the access like to your surgeon? Do you have an open door policy? In our practice, certainly you have an open door policy. You have free access to psychologists, to bariatric nurse, to dietitian, to physiotherapy, and of course myself. I'm on azathioprine immunosuppressants. Would this restrict me in any way having surgery? No. In relation to modifying risk, we just need to modify when you stop taking the medication. And there are lots, it's not just that azathioprine as an immunosuppressant. There's lots of immunosuppressants that patients take that have obesity and come to us for surgery. We just need to decide, right, how far ahead of surgery you need to stop that. Can you have surgery if you have an epigastric hernia? Yes, you can. Do you have to lose weight before having surgery? Abby, what are the rules? from your perspective before onward referral to tier 4?
When we're working with you on the tier 3 weight management program, the aim is for us to support you to lose 5% of your body weight, taking into account how you do that as well, in a healthy way. So looking at improving healthy eating habits, improving physical activity as well within your ability. Hopefully, that will bring about that 5% weight loss for you.
I'm going to throw a hand grenade in here. Weight loss, or the amount of weight loss that you lose before surgery, has no impact on long-term outcomes following surgery. If it was down to me, there wouldn't be a requirement to lose weight prior to surgery. So long as you've been through the psychology, so long as you've been through the dietitian and you understand and you're making an informed decision, that for me would be a far more effective approach. However, again, our hands are tied. This is not a decision that Abby or Nina or Jodie or myself are making. These are the constraints in which we work. Bariatric surgery is a specialist commissioned service. There's only a limited amount of funds, and these arbitrary rules are made by other people. They're really frustrating. Any recommendations on how we may maintain gusto with weight maintenance? That is a really important question. I'm 3 years in now and only just been referred to concern with a further 3 to 5 years, I'll slip. Absolutely. It's hang in there. Make sure that you maintain contact with the bariatric team with these monthly services and webinars that we offer. But it's why people go and look elsewhere. There's only so much that somebody could wait for treatment on the NHS. And that's why you have our complete empathy. And that's why I will never talk down or look down on anybody who looks outside of the NHS and abroad for surgery, because it's so vitally important and it's so powerful, it's so effective. It's very, very frustrating. Do you get put further down or up the waiting list depending on how well you have done with weight loss? No, you don't. It's if you're part of the routine pathway, then it's first come, first serve. Who provides long-term aftercare or vitamin injections post-surgery? So we at Salford, you have lifelong aftercare with us, which is very unique. We have a weight management service that provides lifelong aftercare. You'll have 2 years with the surgical service, and then we have medical weight management to look after you for the rest of your life. In terms of the injections and the medications and the prescriptions, they will be gotten from your GP. I've been refused GA, or general anaesthetic, on 3 occasions. Can gastric sleeve be done without it? It can't be done without it. I'll be very interested to understand why you've been refused general anaesthetic on 3 occasions and where you've been refused on 3 occasions. Again, I can't really comment without understanding a bit more about your certain circumstances, but it's very rare that people are turned down for weight loss surgery. What are the risks? Well, the risks are firstly small. It's a very safe surgery. Certainly in the UK, our complication rates are as follows. The one that people worry about the most is the risk of dying from a complication. I can tell you now, the risk of that is less than 1 in 2,000. In fact, based on our national registry data, in the last 12 months, over the 4,800 bariatric surgeries we've done, only 1 patient has died. So it's an extremely safe procedure. And in fact, those rates of mortality is less than you would expect for gallbladder surgery as well. The risk of requiring further intervention or treatment as a result of something which has gone wrong or as a result of a complication from the sleeve is less than 3%, probably less than 2%, and less than 5% with a bypass. The risk of leaking or the staples not healing properly and you're developing an infection is less than 1%. And if that did happen, you would need further treatment to fix that. So by and large, it's a safe procedure, the sleeve and the bypass. There are longer term implications, which we can certainly go into later on. There's a lot of questions I need to answer. Can I see the waiting list reducing from the impact of people choosing to go abroad? No, it's making no difference, very, very little difference to people, to the waiting list times. What we are doing, though, is addressing the waiting list times at Salford. We are finding lots of different avenues to undertake surgery, to see patients. So it's not just hands up in the air, what we're going to do about it. We are actively working to reduce waiting times for people from tier 3 into the 4-slot clinic or the surgical clinic, and then from the surgical clinic into surgery itself. But I've not seen any reduction in the waiting list as a result of people going abroad. Is a need for IVF treatment eligible for an expedited referral pathway? Yes, it is, depending on your age, of course. You know, if you're coming to the end of your eligibility for IVF, then potentially that could be a reason. We want to help people. We want to provide an expedited pathway. If I could provide an expedited pathway for everyone, we would do that. We almost want you to give us a reason to provide an expedited pathway. But that just has to stay between me and all 230 of you. Finished my year with better health and now referred to this pathway. So I've got quite a few years in front of me. I've started intermittent fasting. Is that a good approach? Again, my concern with calorie restriction is that if it's not done in moderation and it's not done in a sustainable manner, whether that's intermittent fasting or anything else, then it can't be sustained in the longer term. And anything that you can't do for a long time is just not going to have a good effect in the longer term. If that works for you, that's fine. 16-8. So that means 16 hours of fasting, 8 hours of eating and drinking. That seems reasonable. I've lost 17 kilos since September. Will that be held against me? Absolutely not. As much weight as you can lose, the better. That makes surgery safer. If people think that once they've been referred or once they're on the waiting list, they're going to be struck off the waiting list because they've lost weight, absolutely not. If you lose so much weight that you don't need surgery anymore, then that's fantastic. Happy days, you don't have the exposure of risks of complications. But by and large, even if your BMI drops below 35, that will not be held against you. Absolutely not. If health issues are down to being overweight, but you have tried absolutely everything, is there still a long process waiting time? Unfortunately, you know, that's what we've been talking about today. The answer is yes. Assuming UK surgery with well-chosen UK providers, nevertheless, what available evidence exists of various complications, both short and long-term, and the outcomes? Yeah. So it's well documented. The short and long-term outcomes and complications are really well documented. And I've just shared with you some of the serious complications. But in the longer term, certainly with any significant weight loss, there's a risk of developing gallstones. With a bypass, you're more exposed to nutritional deficiencies, which is why you really need to focus on a lifelong supply of those multivitamins and nutrients and supplements. You're going to have to take them for the rest of your life. It's less so of an issue with the sleeve compared with the bypass. The downside with the sleeve, well, the main thing that people talk about is the new development of heartburn and reflux type symptoms. So we think that that occurs in at least 1 in 10 patients, and that can generally be controlled with anti-acid medication. I had my gallbladder removed. Does it prevent weight loss surgery, not having a gallbladder? No. If you suffer from palpitations and you've had your heart checked and they say it's ectopic beats, would this stop surgery? No. I have malignant hypothermia. Is that going to be a problem? No. It just means a type of anesthetic that we give you is a special type of anesthetic. It's not an inhaled gas. You'll have what we call TIVA, or totally intravenous anesthetic, and that will keep you nice and safe. You go right at the beginning of the list as well if you have malignant hypothermia. Liver cirrhosis, and my weight is increasing and I haven't met the 5% target. So what's the best and quickest way? As I have tried a lot. So if I had a best and quickest way of losing weight instead of surgery, I wouldn't be sat here. I'd be sat on my own private island. I don't have any quick, fast answers for you. But liver cirrhosis, depending on the grade of cirrhosis, might still be safe for you to have bariatric surgery. And that might be a reason for you to be considered for an expedited pathway. We don't want your cirrhosis to be too severe. So use that as an excuse. Does the NHS reimburse bariatric surgery in Poland in a private hospital, and whether it reimburses plastic surgeries? So the answer is no. The NHS is not an insurance company. It will not. Now, it's an interesting concept, isn't it? If we can't provide bariatric surgery in a timely manner, well, shouldn't the NHS have an obligation or a moral obligation to find other people that can do it? That's a very good question. Certainly, we've had that discussion amongst ourselves as professionals, but it's again making sure that the regulations are appropriate and you're going to have safe surgery. If you've had problems under GA, can you still have the op? I've had a few ops at Salford. Depends what those problems are. Again, generally speaking, it's unlikely that you'll be turned away from bariatric surgery. It's about managing risk and making sure that the care that you receive is delivered in the appropriate place. For example, you may need high dependency unit, or you may need the intensive care unit as a precaution, but that they are things that we can offer, and certainly they can be offered in certain private hospitals as well. I'm due to see a surgeon at my local hospital about gallstones, as I'm having pain with them and umbilical hernia. They won't do surgery for my hernia until I have bariatric surgery, but that could be a long time. So is it not possible to urgently have the bariatric surgery so I can get the hernia and gallstone sorted? Again, it depends on how much pain and discomfort the hernia is causing, what's in the hernia, but potentially yes. It depends on the circumstances. I have sleep apnea, high blood pressure, and now on rheumatoid arthritis medication. I feel like it's been forever and I've been struggling with my weight. I'm getting on a bit and was hoping by having operations I could enjoy what time I have left. You're absolutely right. You are exactly the type of patient and person that we need to be focusing on for bariatric surgery. You certainly have my empathy. I have Crohn's. Is surgery viable? Yes, it is, but we wouldn't advise for a gastric bypass. We would certainly be thinking more along a sleeve. Anyone with Crohn's or inflammatory bowel disease, we'd try to avoid operating on their intestines and focus mainly on the stomach. I'm not able to have knee surgery until I have surgery with yourselves. This affected my daily living. I was told at the end of last year, then the beginning of this year, now there's another 12-month wait. I have many other health conditions which are affected. Absolutely. And, my advice is keep ringing, keep going, keep ringing and contacting the surgeon secretary to see whether or not we can expedite things. I've completed all my appointments, had meetings with the consultants. What do I do next? You wait. You should have a contact for the secretary. You can certainly ask them to see where you are on the waiting list. Is there a length of time after childbirth that you should wait prior to getting weight loss surgery? No, but if you're breastfeeding, you just need to bear in mind that surgery and anaesthetic might interfere with that. And of course, after childbirth, there is a period of time where your weight fluctuates and reduces, particularly if you are breastfeeding. So if you do reach a plateau, that will be a reasonable time for you to consider surgery. Is it true that you can't have surgery if you put weight back on? So I think that's an eligibility criteria question, Abby. I don't know whether you have any comments on that, but.
If you're still in our service, and this was before us referring you on to Salford Royal, we'd have a look at why you've regained some weight. So have you been unable to stick to some of the healthy changes that you made? And if so, then why is that? Just thinking about the long term after surgery, you want to be able to, it requires a lot of lifestyle changes in the long run, and you want to be able to keep up with those to make sure you keep healthy and keep side effects of surgery to a minimum. So yeah, if you're still with us in the service, we'd have a look at why you've regained the weight and try and help support you with that before we send a referral.
Nina, you're about to say something.
Yeah, I was going to say, just to add to that as well, as far as I'm aware, so if you've achieved the 5% within your tier 3, whether that's More Life or ABL or somewhere else, and we refer you, and I'm aware there's a long wait to being picked up from Salford. So if when they pick you up, you've regained some of that weight, It wouldn't be a case of getting referred back to your tier 3 service, so More Life or ABL. It would just mean that they would support you in losing that weight again. So it could delay your surgery further at that point. So you wouldn't have to start the cycle again, but it could add an extra delay, which I'm sure no one wants.
And what I will add to that is, we're not monsters at Salford. We completely empathise that these long waits are not helpful and they do result in weight regain in some patients. But so long as we are satisfied and reassured that all the necessary steps are put into place for you to be able to manage post-operatively, then a little bit of weight regain is not a big deal from my perspective anyway. I've had patients who have, during the pandemic, have put a bit of weight on during the wait when we were doing no surgery. I certainly didn't hold that against them. Can I request to be referred privately for bariatric surgery? If so, would the cost be covered by the NHS? It wouldn't be covered by the NHS, but one strategy that we are trying to implement is using the private hospitals to undertake some of our bariatric surgery. So we currently are in partnership with the Oaklands Hospital at Salford, which is just across the road from Salford Royal. And you may be offered surgery there if you fulfill certain criteria. So usually if you're lower risk, you don't need high dependency or anything like that, you may be eligible for bariatric surgery, still by the same service, by the same surgeons, and you'll still be looked after by the NHS service. But that's an example of how we're trying to expand the service for now. Factor 5, Leiden, we've talked about. Is it possible to have a gallbladder removal at the same time to reduce blood loss? Yes, it is. Sometimes it is, it's about being pragmatic at the end of the day. There are certain procedures that I wouldn't do at the same time. We've mentioned umbilical hernia. I would want somebody to completely lose as much weight as possible before treating an umbilical hernia. So I wouldn't treat that at the same time as weight loss surgery. With respect to gallbladder surgery, yes, absolutely. But again, if the focus is weight loss surgery, we would focus on that. And if it's safe to proceed with gallbladder surgery, then at that point, yes, we would probably do that. I'm a type 2 diabetic with sleep apnea and the weight management team have recommended weight loss injections. Will this help with my weight? And also I have an umbilical hernia that is causing me discomfort. Would you recommend having that before bariatric surgery? Yes, if you're offered the injections, try them. You're not going to lose anything by trying those. And you wouldn't have your umbilical hernia treated before weight loss surgery because the risk of the hernia coming back is extremely high unless you've lost the weight first. Right, I've been on the program since 2020 and have a hernia from open abdominal surgery. I've had conflicting information from these seminars dating back to when there were meetings and we were all on camera. Some saying my hernia will be corrected in surgery as and when I get it. Others saying that it will not be done. Should I be contacting my GP about hernia surgery as it causes me issues and discomfort? In addition, I was referred 10 weeks late by, More Life, naughty More Life. Pay stuff in February, so I'd not adjusted their waiting list. I head to brick wall every time I get through to Salford. Okay. So maybe we can take Amelia's details and see whether she's already been referred through. My general rule is that if you have a hernia, an abdominal wall hernia, not a hiatus hernia, that's a separate matter altogether, an abdominal wall hernia, you are much better having your weight loss surgery done first, losing the weight. It will make the surgery for your hernia easier. It will reduce the risk of the hernia coming back again. I have had endometrial cancer plus ovarian cancer, had chemo and had a full hysterectomy, so the consultant found I had endometriosis. Would I still be eligible for bariatric surgery? Yes, you would be. Endometriosis in and of itself is not a reason not to have surgery. Do you get to choose which surgery we have, or is that decided by the surgeon? No, it's a shared decision-making process. You have ultimately, you're the one making the choice. What I'll always say to patients is there's never a single best answer or a single option that's best for every single person. It's a matter of choosing, understanding that there are trade-offs with each and every option. It's a matter of understanding what those trade-offs mean for you and your set of circumstances. So we've talked about the sleeve gastrectomy, and there's a small risk that you can go on to develop heartburn. Well, at the same time, if you're more concerned about that, you might consider the bypass, but the bypass has longer term implications of nutritional issues. And if you're younger, you might say, well, actually, I don't like the idea of potential long-term nutritional issues with a bypass, and therefore I'll go with a sleeve and I'll accept there's a chance of developing heartburn. So it's about weighing up the pros and cons for your set of circumstances, and we will talk about that and those circumstances and those, that process with you during your clinic consultation. If I choose to go down the private route in the UK, would B12 injections and supplements be available on the NHS, or would I have to buy these? I would say 99% of GPs are very happy to support patients. That's been my personal experience. And certainly what I would do, I would send out a comprehensive discharge summary to make things very easy for the GP. I have had one or two situations or scenarios where the GPs come back and said, no, we're not going to support, at which point I have contacted the GP personally, and we've gone through and negotiated something for the benefits of the patient. At the end of the day, if patients are looking to take on the cost of surgery, they're saving the NHS money in the longer term. They're reducing their own need for medications in the longer term and the risk of developing diabetes and all of these things. So you're benefiting the wider society having this type of surgery as well as yourself. I had an eating disorder when I was younger. Now I'm overweight due to medication down to health conditions. And now I have a very low B12 and iron level. Will any of this go against me? No, it won't. I've done Slimming World 3 times and Weight Watchers while on this journey and literally get nowhere. So the area that I would focus on is the eating disorder side of things. It might indicate that you need some additional support from a psychological perspective from our psychologists and psychotherapists. And it's really important. Again, it highlights why aftercare is so very, very important. So that wouldn't count against you. It's about optimizing you, making sure that you are in the best physical and mental state possible before surgery so that you have safe surgery and a good outcome in the longer term. After the MDT, agree to putting you forward for surgery and due to conditions affecting my eyesight, how long would I wait for surgery? Because it scares me that the wait can be 3 years and I could lose my sight before I make it. So from the time you are listed for surgery, from the time you are seen by the surgeons, currently the wait time is anywhere between 12 and 18 months. Sometimes we can make that much shorter. We're trying to move much closer to 52 weeks. So that means a year. And then hopefully we'll start reducing that further still. We are working really hard to reduce the length of the waiting list as much as possible. So I absolutely do not expect it to be anywhere near 3 years. How will HIV affect having it done? When stomach liners make HIV tablets not work, will medication be changed? Yes, again, it's about managing the situation. It's about understanding what medication you need to take and whether they need to be changed. And we will work with the specialists who are looking after not just HIV medication, but any other medication to make sure that the tablets and the meds that you need will be as effective as possible after weight loss surgery. What happens if you continue to lose weight after surgery and this ends in losing too much weight? Very rare that happens. Your body has an internal thermostat or system that regulates and knows when it reaches its most desirable weight. Very, very rarely in the case of, say, the gastric bypass or some more extreme surgeries like the duodenal switch, you may see significant nutritional deficiencies, which may then lead to severe amounts of weight loss. It's far less likely with the sleeve gastrectomy, and again highlights the importance of proper support and aftercare. We want to make sure that we are identifying these problems as early on as possible, so you never get to the position where you've lost too much weight. Do you have any tips on finding the right weight loss surgeon in the UK for going private? Well, I've given you my 6 areas to consider: the quality of care, the cost, the aftercare and support that you'd be provided with, and then some of the other factors in relation to going abroad. Shop around, see more than one person. I'm very happy to speak to people if that's something that they want to consider, and my details are available online anyway. I have familial hypercholesterolemia. Will bariatric surgery help with it? To a degree, yes. There is some evidence that it will help in lowering your cholesterol. It might be that you will still be on those statins for the rest of your life, however. Non-urgent bariatric surgery at Salford, what's the waiting list time? As I said, it's between 12 and 18 months currently from the time of you seeing the surgeon. Do private, do a parent plan at your clinic? Quite sure what that means. Payment plan. Okay, yes, that's right. So we talked about payment. Yeah, there are lots of different ways to pay for private treatment in the UK. You can do that using installments, getting a loan, credit, loads of different things. The hospitals themselves provide dedicated people to help you with that. So yes. I'm on biologicals for Crohn's. Can I still have surgery? Yes, you can. What age limit will you take? Only I'm aging fast. So there's actually no upper or lower age limit as such. We don't discriminate on age. But what we do is take into consideration a person's physiology and health-related medical conditions. I've operated in people in the 70s because they've been fit and generally well, and they would benefit from surgery. And so age in and of itself is not an obstacle. How many procedures are you doing a week now? So anywhere from about 10, something like that, 10 procedures a week. But of course, there's all kinds of circumstances, doctor strikes, bank holidays, other escalations in care that require priority. Unfortunately, we are trying to prioritize bariatric surgery as much as possible. Who decides which surgery you get? We've talked about that already. It's a shared decision process. Age limit, we've answered that one. Once you've lost the 5%, how long before surgery? If you put it back on, do you have to start from the beginning again? We've answered that. Would I be the doctor doing your surgery if based in Manchester with More Life? If you come into the Salford hospital, you are allocated to a surgeon. And, I have to say, regardless of which surgeon you go to, you'll have an excellent service. But of course, it's patient choice at the end of the day. If you wanted to specifically ask for me, then I'd be very happy to offer that. What's the difference between a gastric bypass and a minion, which is better? The gastric bypass was first developed in the 1950s and 60s. It's the yardstick, it's the gold standard against which we measure all other types of surgery. We know it like the back of our hand. The mini gastric bypass is a relatively new procedure. It was developed probably about 10, 15 years ago by a surgeon in the United States. The main benefit of the mini bypass is that it's technically more straightforward to undertake. The downside to the mini bypass, we don't really have long-term data and evidence in the same way that we have for the gastric bypass. And so I'm a bit concerned about offering the mini bypass as a first port of call for people who are much younger, because I don't know what the long-term implications will be. In terms of short and medium and longer term results from weight loss, we think that they're very, very similar. Okay, I have PCOS, been with tier 3 for a year, changed my diet, I've only lost 10 pounds in a year, I have a fatty liver. Am I likely to be given access to bariatric surgery? I hope so, because you'd be an excellent example of a person who would benefit from surgery. Vasospastic angina, would that go against me? Again, it depends on how bad it is. We need to optimize. It might be that we decide, yes, surgery is absolutely safe for you, but you need to go into the intensive care unit or high dependency afterwards. I have an extremely fatty liver. Can I be moved forward? So that in and of itself wouldn't be a reason for you to be expedited or put up the waiting list. Most patients, unfortunately, do have fatty livers. I have ME and chronic fatigue syndrome, which makes it very hard to lose weight, not at risk of diabetes. Can this be a criteria for expedited pathway? Unfortunately, not everyone can be on an expedited pathway. It all very much depends on a case-by-case basis. The only reason I'm not being prescribed weight loss drugs is due to my sugar being 37 instead of 42. Do you see these guidelines loosening? I have sleep apnea and fibro. I'm having surgery on my ankles as they can't hold me up. I've also had a preventative double mastectomy with LD flap reconstruction, caused a lot of problems with movement exercise. Yeah. So the guidelines, as with anything in time, I'm sure they will be relaxed in time. I don't know when that would be, unfortunately. The only reason I'm not being prescribed weight loss, I know we've done that one already. Do you have any experience with lipedema patients? Yes, absolutely. That is not a reason to avoid or for you not to be considered for bariatric surgery. We've answered that one from Erica. I'm very overweight, BMI over 40, bad bowels that shut down on me, and this makes losing weight very difficult. I also have lower back problems. How long will the wait be to see a consultant for surgery? Yeah, so as I said, we had 500 patients at the beginning of last year waiting to be seen in our clinics. We've cut those numbers right down. We're running extra clinics for you to be able to see us. We're running telephone clinics in order to triage patients and get that process speeded up. We're seeing double the number of patients that we would usually see in clinic per surgeon. So hopefully we'll make a real dent into that waiting list as soon as we can. Had my first phone call 7 months ago, had no calls or updates since. Is that normal? It can be, but I would advise, Christopher, for you to contact the surgical team and see where you're up to. Gail, would being on steroids affect the surgery? No, again, we would just need to understand the level of steroids that you're on and whether or not we need to stop them beforehand or whether we need to change the medications that you're on ahead of surgery. I have an umbilical hernia that I'm having to hold in to walk. I'm having a CT on the 15th. Well, good luck, Katrina. And as I've said, we don't routinely operate on an umbilical hernia until you've lost the weight for the reasons we've talked about before. Lynn says she's had an MI. Would that affect my surgery? No. Again, it's about making sure that the strategies and the steps have been put in place in order to make surgery safe for you. Does diverticulitis affect having surgery? No, it doesn't. It might affect the type of surgery that we offer, depending on how bad the diverticular disease was or is, but that we'll talk about that in the clinic. I have abnormal cells and HPV and endometriosis, but will not perform a hysterectomy till my BMI is lowered, and then there's another 2-year wait for hysterectomy after weight loss surgery. Yeah, so that would be a reason for expedited surgery. We see that quite often. So if you've got abnormal cells on the cervix, and that increases your risk of cervical cancer, and also endometrial cancer, if you have abnormal cells on the endometrium of the uterus, then that would be a reason for expedited pathway. I was seen about 1.5 years ago and put onto the injections. I've not heard anything since. Will I be contacted? What I would advise most people to do is if they've not heard anything, you be the one that becomes proactive and contacts Jodie and contacts the team's secretary just to understand where things are up to. One of the challenges that we are trying to overcome in our patient group who are waiting a long time is how do we best keep people updated with their current wait times. So I think that is all the questions now. 105 questions answered. That's got to be some kind of record.
I think it is a record.
So it's really been a pleasure to speak to you all and answer your questions. And I hope that we will meet each other soon in person. Even if I don't operate on you or don't offer you surgery, we work in a very collaborative and collegiate way at Salford, where we look after one another's patients when they're in hospital. We're working really, really hard to try and speed up the process for everybody. I just want a little bit of patience from people. I know you're being so patient. We're working within constraints. And if you do think about alternatives, please think very carefully about who you go with and what the questions are that you need to ask of those people that potentially may be carrying out surgery.